So welcome to the Advanced Practical Workshop. This is specifically designed for general practice nurses in Australia to initiate palliative care and supportive care assessments and advanced care planning using specific tools in your general practice. I'm Jennifer Gavin. I work for HammondCare and I'm on a secondment to this project. I've worked for HammondCare for the last 9 years and I'm a registered nurse with a long and varied history like us all. And with me as a co-facilitator today is
Jolan Stokes, and I've been with HammondCare about 5 years, registered nurse, trained in the 80s, converted to a degree in the 90s. And again, my background is palliative. I was the clinical nurse educator at Moringa, which is a palliative specialist. And again, on a secondment role here. It's been such a pleasure.
Thank you. Now, I just want to draw your attention to the bags you have in front of you, and in particular, two of the resources that I'll get you to put out in front of you. It's the one called the Participant Workbook. There's other things that you'll be able to use later and other resources to draw upon. But if you could have the Participant Workbook in front of you, because all the slides and the tools we're going to talk about are in there. And the second thing is the laminated one-page advanced guide. If you have those two things in front of you, and so that you can follow along with us as we go through. And most certainly, please, we want a discussion and conversation, and so don't stand on ceremony, ask a question, have something to say anytime you like. We're very, very happy to hear what you have to say. You'll see the agenda is in your workbook, so I won't go through it in detail, but I will just point out the last item. Part of this advanced project is that we're doing an evaluation and that we will give some time at the end if you would be so kind as to give us your feedback and fill out an evaluation form. Okay, is everybody right? So just a little bit more about the project. We're funded by the Commonwealth. We're a national consortium with our friends like Liz from the University of Wollongong, and it's led by HammondCare, as we've explained. We have an expert advisory group, including international representatives from some of the tools that we're using. We are APNA Endorsed for this training, for this workshop, and also our online training is APNA Endorsed, as well as the advanced toolkit that there is a copy for you to use later in your pack. The toolkit is also and has been accepted as a clinical resource by the RACGP, and it's specifically designed for nurses working in general practice in Australia. And like I said, we've done workshops. Jolan and I have been on the road for the last 3 months to every state and territory, and we're in Hobart today. Okay. Good. And I'm Jennifer, and that's Jolan. And so, your learning outcomes for you to look at in your book. I'll just particularly point out that we're going to particularly talk about identifying patients who may benefit from the advanced care planning screening interview, as well as those with the advanced care planning screening interview and the full supportive care assessment. We're going to look at all the tools and use them. So we're also going to talk about discussing and evaluating the tools with your GP when you have done them, and how you can implement these tools into your clinical practice. I'd just like a quick show of hands. Has anyone had the opportunity to register for our online training? Has anyone completed our online training? Right, there's a few. Very good. Anyone had the chance to use any of these tools on any of your patients yet? No, that's okay. We're finding that a lot of people like to come to the workshop after they've done the online training, just to, nut out and have a discussion and put it all together and make a bit more sense. So that's great. Some of the videos are very similar to the ones on the online training, and it's certainly a good refresher for you as well, and helps us focus our conversation around particular points. So just to let you know, they certainly work together, the online. If you haven't done the online after this workshop, you might be enthused to go back and do it, and it's there for you to do and come and go at as you want. It's 2 CPD hours as well, and it also gives you access to lots of the resources after you've finished. So certainly just because you've come here doesn't mean that you can't do the online afterwards, and you might want to refresh yourself. And this also, having this discussion and going through this with us might make it clarify some of your questions along the way. So please yell out if there's anything we could clarify for you. So we're going to start with a bit of a refresher. Why not? First thing in the morning, let's refresh. And the first thing that we might look at is definitions. Good place to start. Focuses us on the conversation. And in particular, the definition of advanced care planning. Very important, and I will just take a moment to read it for you. A process of reflection, discussion, and communication that enables a person to plan for their future medical treatment and other care for a time when they are not competent to make or communicate decisions for themselves. So that's a very important part of that definition for us all to keep in mind, that it's for a time that they are not competent to make or communicate decisions for themselves. And certainly if we're going to be talking to patients about advanced care plan, it's sometimes good for us to have a very clear, succinct definition for us to be able to refer to, so we feel confident in telling someone else about it if we know, feel clear that we know what it's about. Now the other two definitions, which I won't read out in the interest of you not having to listen to my voice all the time, palliative care and supportive care. If you just want to take a moment to have a look at those definitions. And you will notice that in actual fact there's a lot of similarities between them. That they both involve a focus on quality of life, improving symptoms, providing holistic care for a person with a serious illness. And we also like to point out that it's often seen that that supportive care is a term that's often used in general practice as a gentler way to introduce the concept. And that it's also most important to point out that by the time someone is on the path to needing to have a referral to a specialist palliative care, it's important that is explained to them what specialist palliative care means. We have a video on our online training session that helps where a patient has been told and is talking to the nurse, and they have that connotation of I'm too difficult for you and you're fobbing me off and you don't want me anymore type thing. So it's good for them to be able to have it explained if you need to, that we're seeking expert treatment to help look after you and have you have the best quality of life, people who are the experts in pain relief and symptom management. So that's an important thing. Just again to tell you that with Advance, we've got a suite of resources for you to use on our that you can access through our website, as well as the training videos, as I've mentioned, the online learning modules, and these workshops. And we're also offering tele-mentoring with Jolan after you've done the workshop and when you get out there into your real world and you're trying to put this in place, and you might want to have someone to chat to, you might have a challenging situation, or you might want to troubleshoot even before or after. You might want to try the tools and think, well, that didn't go so well, so I'd like to talk to somebody to see how I can. So certainly that is available after the workshop, and in the survey that we will give you later, there's a place where you can indicate for us if you would like to be contacted regarding this. And the toolkit is what you can have as a resource go-to book when you go back into your practice. It has all the tools in there and a lot more information for you to refer to. It also shows how you can systematically implement the 6 assessment tools into your clinical practice. And these tools were informed by a literature review of the best available evidence. That's why they were chosen by the expert advisory group. We also had feedback from general practice nurses and GPs and Carers Australia as input into these tools and while we were putting all of this together. And in actual fact, I came to the APNA conference 12 months ago and met lots of lovely people who gave me great a wealth of wisdom and good advice with going forward with our project that we were just starting. So it's lovely to be back again. Next, the project, the aims and benefit of the Advanced project is listed up there in front of for you, and it's also in your handbook for you. And it's to improve the care outcomes in Australian general practices through being able to have earlier consideration and uptake of advanced care planning, particularly in the older and the chronically ill patients. A valuable thing for everyone, but particularly those people. It's also about identifying your patients who may be at risk of deteriorating and dying, and trying to efficiently assess them and address any of their concerns and needs, and also those of their carer. Because very important with someone with who's deteriorating or with a chronic illness is their carer, because often that's, if that falls apart or their needs aren't addressed, well then that has a significant impact on the patient. It's also that we're very good at looking after the very clinical things, but sometimes we need to sit back and take a full assessment of where they're at and what's their concerns and needs and where we can help them with that. So that's why the tools that we have chosen will help with that. We're also hoping that it will benefit by more appropriate and timely referrals to specialist palliative care services, if that's what's required. And we would also like to increase your confidence as general practice nurses in initiating the conversations around advanced care planning and screening for supportive care needs. So why is advanced care planning important? What have you seen in your practice, or maybe you've experienced, that would make you think that having conversations about advanced care planning is an important thing to be doing?
I think it's often when I come across as conflict within families.
Yes.
And that is extremely distressing for the person concerned.
Yes.
And very distressing for the families.
Yes.
So for me, it's just so important that those conversations have taken place.
Yeah.
Because bedside fights.
Yeah. And it's often at a crisis. Crisis over a bedside, in an emergency department, and you think...
It often means that we do things, I mean, just because we can do things medically doesn't mean we should. And that's why we need to have that conversation as early as possible.
Yes, because it can be a very difficult time. Yeah. And until you start having the conversation, you don't always know that there's conflict out there.
No. People actually think their family knows what they want, and often children or family members think they know what their parent wants, and it's not till they have the conversation they discover that they have no idea.
Or they even think that they know, oh no, most siblings will agree with me.
Yeah.
Guess what?
There's always one.
Yeah.
So, no, it's
Yeah.
very important.
Yeah. Anyone else?
The legal paperwork, not to do with medical stuff, but wills and all those things afterwards, the family members are trying to pick up the piece and go, well, where's the mums and dads financial stuff now they're gone, and and again, family conflict coming into that.
Yes, exactly. And that, yeah, sorry.
I was just going to say, I think it's really important to not let people get distracted and think that advanced care planning is about their finances and their wills. Because people often go, oh no, I've done that. And I go, well, no, that's actually not what we want to focus on. We want to focus on what care decisions you want. And that can often really muddy the water.
Yes, and that's after you're gone.
Yeah.
Really, the practicality of that. So yeah, but in all of that conversations, sorry? They do, and by starting a conversation, one will lead to the other or the other lead to the other. So in actual fact, it's making everything a lot more clarity and easier for people to follow. Yes, while they're alive, while you're enacting an advanced care plan, and then when they've gone. You're right. You'll get a lot more clarity with both.
I've had a few that elderly people that are very adamant of what they want, and it is in conflict with what you know that the family would want for them.
Right.
And so it's a way of making sure that the family don't make an emotional decision to not to cremate them or not to do something that the person really does want. And so it's about choice, I suppose.
It is.
And putting it in writing.
And it's about being clear about the choice. You know, look, the best intentions, and most of us, and we would like to think the best of everybody, we all want to do what's best for our loved one, but if we don't really know, or if I know and the rest of the family don't know.
They don't agree.
Yes.
They might want to be cremated and
Yep.
the ashes, spread from the boat that they liked, but the family would like them buried in a family plot. So it's to do with
Both.
wanting what the patient wants.
I think they also need
Doing
to
what's
understand you
done.
can change your mind.
Oh, that's a very important
My dad
part.
was always very clear that he wasn't going to go into care, and when the time came, he wanted us to do something. So when the time came, I said, Dad, what do you want me to do? Like, I'll do it. I'll send you to jail, but whatever you need. And he said, no, I've changed my mind. He says, I can't, now I'm at this point, I can't do that. So it's actually really important to know that it's not set, that it can be changed.
Oh, constantly review. And what I might decide in my 30s will be different to my 50s, to my 80s, and you're right. And maybe different when I'm given a diagnosis, yes. Sorry.
What I found interesting too, doing that online thing, was it's not necessarily end of life to start planning these things. Chronic complex diseases, okay, but you start planning. It's not necessarily palliative care as an end of life care.
Well, life is terminal, so we could all have the conversation.
Yeah, but we're not very good at acknowledging that life is terminal, and you're exactly right.
Mention advanced care planning to someone with heart disease or something, and they're saying, "Oh, am I going to die?"
Yeah, you know something I don't know. Am I worse? And you're right, palliative care often has that connotation of end of life. That is one stage of palliative care, but it's about the palliative journey. Yes.
I also think the advanced care planning is important for patients who don't have family.
Yes.
Because I've come across really
Yes.
they don't have anyone. When we do the over 75 health assessment, my lady recently, never married, doesn't have children. I said, do you have any relatives in prison? Not one. I have a friend. So then they've got no one, so no one to know their wishes even. So I think that's important.
That's a very important thing, and it's very important for you to know that, unless you started that conversation with her, even to find out that very important thing, or that it is Mary, my neighbour 2 doors down, that nobody might have thought to contact. So that's where it needs to be communicated and in place. Yes, exactly.
And we've had 2 people pass away in the last couple of weeks. One was a very young man, 48. How do I put it politely? As my GP says, between him and his son, they had an IQ of less than 100. That man came into us very, very, very ill, and the son's just sitting there saying, "Yeah, he'll be fine." And within a week, he's passed away. When the police went at 1 o'clock in the morning to the caravan to take the body, that young man had been sitting beside his father for several hours watching TV, didn't even know he passed away.
Oh my goodness.
And his comments to the policeman were, "Who's going to pay the rent?" And because he wanted to make sure that he could play his games on the constant. So there's that sort of thing. And then we've had an elderly lady, her and her husband both a little bit low in their IQ rate, and he is still, like right up to when she went into palliative care, they had no understanding that this was the end very, very soon, and within a week she passed away. But he's still in this, don't know quite what's happening.
Yes, you would see a lot of very heartbreaking cases out there. In the interest of moving along and getting us into morning tea, I'll keep going. Thank you for your input. Look, this slide just basically backs up everything that you're saying in the research. It says how important it is, how it helps clarify what you want. One important thing that I like to point out is it also helps clarify people who have a chronic condition about what their current treatment might, or how long they want to stay on their current treatment, as well as their future needs. So it can help by starting these conversations, make you think about the here and now as well as the future. And certainly one of the other things is that it does reduce the stress, anxiety and depression in the surviving relatives. If I know I've carried out mum's wishes, well then that will hopefully make the grieving process easier for me than if there's been all that conflict and we didn't know and we thought we were doing the right thing. So important components of an advanced care plan are the opportunity to reflect, like we've just discussed. How would they want the decisions made? And one of the very important first starting points is who would be their preferred substitute decision maker, like you said, for the neighbour who didn't have anyone. And therefore, what are your unique values, concerns and wishes about medical treatment and care in the future. Important that we do point out to them that, as mentioned, it's an ongoing discussion. It requires regular review. Just because you do it, and it seems like a lot of effort, it's not set in cement. It's at being able to change any time you change, and we all change our mind, sometimes more than others, but that's what it's all about, being able to know just because we sit down and do this now doesn't mean I can't change my mind like your dad. Important to document, and that's why it's when we talk about the advanced care planning screening interview that Jolan's about to go through with you, it's a chance of documenting somewhere, because we can often have discussions but not necessarily formally document it and nor be able to easily refer to it in the future. And even if you're only documenting where the discussion is up to, like Jennifer is interested in taking this further, or Jennifer doesn't want to talk about it anymore, and who my preferred substitute decision may be. It would be ideal that the process follows on and takes some time and you go to getting a formalised legal document, but where about we start, because that's ideal, but it may take some time and to get to there, and that's in the meantime you can be doing things. And also, very importantly and a bit obviously, if the substitute decision maker isn't known, then they need to be involved in it. So even by having that conversation and clarifying who would be the substitute decision maker, then you have to go and speak to that person, and that starts the conversation. If I'm going to make the decisions, what is it would you like me to do? So why introduce advanced care planning early in general practice? It ensures people have the opportunity to discuss, like we've said, in case of a sudden event and we don't have the crisis over the bedside. It suggests that people would often prefer to start this conversation when they're relatively well and in a familiar setting, which is you in general practice, where they often are. And if it's introduced in a early and in a routine way, it becomes less daunting. We normalise it. It's something they get used to discussing every time they come and have an over 75 health assessment. Here I am, I'm going back again from over 75. That woman Jennifer's going to bring up that subject again. Maybe now I should start doing something about it. I heard her talk about it enough. So why screen for supportive and palliative care needs? Well, like we said, often people with chronic conditions can be experiencing a range of other unmet needs, not necessarily their clinical ones. We can be very good at that, but there's the other things that could be adversely affecting them or their carers' well-being. And that's very important that we take stock at that and have a simple and systematic way of assessing, is there more we can do? And that's why assessment tools are a systematic way to identify their needs and concerns and see how we can help them be addressed. And that may lead to people being referred earlier to specialist palliative care services. Now, the advanced guide that you have, I'll get you to get that in front of you at the moment, has 3 phases. It's colour-coded for you as well, and I just get you to have that in front of you as we're about to watch a video of Professor Josephine Clayton
The Advanced Guide
introducing it.
will systematically implement 6 screening and assessment tools to initiate advanced care planning and palliative care in general practice. The Advanced Guide describes 3 phases. The first is to identify suitable patients. The second is to screen for their needs. And finally, to evaluate the patient's needs. Let's look at identified patients in more detail. The following patients would be identified within the practice. Any patients who are older than 75, and it might be a natural time, for example, during the 75 plus health assessment. And any patients who are aged over 18 who have 1 or more chronic or debilitating illnesses. The surprise question and the SPIT can then be used to identify which of these patients might benefit from a full supportive and palliative care needs assessment. Consider the surprise question first. Would you be surprised if this patient died in the next 6 to 12 months? You can ask yourself this question, or you can discuss it with the GP. If the answer to the surprise question is yes, then these patients don't need a full supportive care assessment at this stage. However, given that these patients all are elderly or have a chronic illness, It's very appropriate and timely to begin to discuss advanced care planning using the advanced care planning screening interview. If the answer to the surprise question is no, the SPICT is used as a second screening tool. We suggest you discuss this with the patient's GP and together determine whether the patient meets the SPICT criteria for being at risk of deteriorating and dying. The second stage of the implementation guide is to screen for patients' needs. Patients who meet the SPICT criteria for being at risk of deteriorating and dying will benefit from a full
supportive care needs assessment. This assessment will help to identify any unmet needs and also help the patient to work out their most important concerns, symptoms and priorities. For these patients, you or the GP will need to explain the reason for the assessment and invite the patient to come in for a meeting with you. It's a good idea to suggest to the patient that they book in for a long consultation with the GP immediately after they see you. It's also a good idea to encourage the patient to bring their carer along to the appointment if feasible. At this full supportive care assessment, you administer the following tools: the Advanced Care Planning Screening Interview, the IPOS tool, and the NATCC Patient tool. If the patient brings their carer along to the appointment, it's a good idea to suggest that the carer completes the carer tool and then makes an appointment to see their GP on a different day. Alternatively, you may come across carers of patients with chronic illnesses on another occasion and suggest that they complete the carer tool. For patients who don't meet either the SPICT or the surprise question criteria, we suggest that you incorporate the Advanced Care Planning Screening Interview into a regular assessment, such as a 75 and over health assessment or a chronic disease management assessment. The final phase of the implementation guide is to evaluate the patient's needs. After seeing you for the full supportive care assessment, the completed tools are given to the GP. The GP can then review the patient's responses to the Advanced Care Planning Screening Interview and see what they've written about their most important concerns, symptoms and priorities. The patient will then be reviewed by the GP, who can determine the care plan, and also begin to discuss advanced care planning if the patient would like this. After the patient sees the GP, we suggest you touch base with the GP using the referral triage tool. The referral triage tool will help to determine whether the patient's needs can be met by the GP practice at present with the current support systems in place, or whether the patient may need referrals for additional support, including considering whether early referral to specialist palliative care is required. Any required referrals will then need to be discussed with the patient and or their carer, and the next appointment booked in for the patient to see the GP practice. For patients who had the Advanced Care Planning Screening Interview only, further consultations with you or the GP can be arranged to further discuss advanced care planning if the patient would like this. In summary, the Advanced Guide describes a template for implementing 6 screening and assessment tools to initiate advanced care planning and palliative care in general practice. In the first phase, 2 subgroups of patients are identified. Firstly, patients who might benefit from a full supportive and palliative care needs assessment, and secondly, patients who might benefit from the Advanced Care Planning Screening Interview alone. In the second phase, you as the general practice nurse screen for the patient's needs and or their carer's needs. And in the final phase, you and the GP evaluate the patient's needs and determine if additional support is required.
Referred to all the tools by name, lots of words there, but we're going to break it down and use each of the tools in some case studies that Jolan is going to go with you.
Now we state that we have 6 assessment tools, which sounds quite a lot when you first think about it. But what we're going to do is use a couple of case studies and actually show you that you're actually already doing this to a certain extent. But what we're doing is we're doing it in a more sort of systematic way. So the first case study is Mr. Barrows. Let's have a look at his case history. Now he's 80 years old. He does live alone. He's got chronic hypertension. He walks with a frame. He's got some chronic osteoarthritis. But really he's fairly well. And he's presenting to you for the 75-year-old health check. Now looking at your advanced guide, what is the first thing you should be thinking of? What should be triggering you looking at the advanced guide? Can anyone? Sorry? That's exactly what I thought when I first looked at this. But before that, because what we're saying with this suite of tools, of the advanced care planning and screening tools, etc., it's not for every single patient. There's no way in the world you're going to be able to do that. So what we're really looking at is to see which cohort of patient would he fit into. So we're really targeting two types of patients here that will be coming into your practice. So where do you think Mr. Barrows would fit in? Absolutely. So we're looking at number 1, age 75 years and over, and he's coming in for his health assessment. And then the next thing we do is ask ourselves the surprise question. Now, who's heard of the surprise question? Great. That's fantastic, because I must admit I've heard of this surprise question. I was hospital trained for a very long time. And this is really one of our first assessment tools that we're doing. So this is just a question you're asking yourself. So let's ask it. Would you be surprised if Mr. Barrows died within the next 6 to 12 months, just looking at his case history at face value? Yes. Basically, yes, we would be. Brilliant. So that's our first assessment tool. Now the second, so he really does not need at the moment a full sort of supportive care assessment needs done. But because he is over 75, we should be maybe start talking about advanced care planning. And this is where we're going to be looking at our advanced care plan screening interview. So if you just turn over the page, we've got a copy of this. We will be watching a video of Paul talking to Caroline using this advanced care plan screening interview. But before we go on to it, I just want to make sure we're a bit orientated towards it. Now, this is a structured interview of 10 questions and prompts. This was actually developed by our Associate Professor Josephine Clayton, who's with us today. And so it's a national Australian tool that was tweaked and evaluated in the acute and GP setting. Before I move on, I just want to state I've used all of these tools out there with patients. I've visited people at home, I've been in specialist clinics and also GP clinics. Because before I went on the road and was doing these advanced practical workshops, there was no way I could stand here in front of you all and talk about them if I haven't actually used them, and I have used them. And this tool is absolutely brilliant because what it does, it's a way of being able to initiate the conversation. And all the research has stated that initiating a conversation is actually the hardest part. And patients and the public would prefer to speak to a nurse about it than actually their families on most occasions, because you're not as emotive and they trust you. So let's have a look. Now the front page really is instructions, notes for the interviewer. There's 2 types of sentences there which you can use as a way of introducing the topic. Like the first one basically states, as part of our normal health assessment, we ask everybody, have you thought about your future healthcare wishes? You don't have to say those words, but they're a prompt for you to use them. When we actually have our working break, a lot of the nurses in the past have actually looked at this and started talking to their neighbour about advanced care planning. And after the first few times they initiate the conversation, you're using your own words. But this is a really good guide of being able to actually state it. And what we're trying to do, as Jen said, is to normalise the conversation. This is not meaning that you're going to be dying in the next couple of weeks. This is something that we're doing. We're a death-denying culture, and we don't talk about it. So followed is a couple of statements there. There's a definition of what is advanced care planning. Because this is really important that they understand this is a process, this is not going to happen in one session, and it's good to be on the same page. Then we have instructions for use. So again, pages 3 and 4, 2 and 3, we've got around about 10 questions. So the unshaded parts are actual questions to ask. The shaded are prompts depending on their answers. And there's also areas there that you can start documenting. Because there's 4 main aims of this particular advanced care plan screening interview. 1, to introduce the topic of advanced care planning. 2, have they actually heard about advanced care planning in the past? 3, have they had any talks? Has anyone given them a brochure which you're not aware about? Have they started one? And 4th, really important, have they thought about a substitute decision maker? Because when I used this particular tool, I actually interviewed my mother, and I had my sisters over. My mum lived in Launceston, and there was all of us together, and we went through it, and she wanted 2 substitute decision makers. Me, because I am the nurse, and my other sister, because she wasn't the nurse. So it's really important that they start thinking about that, because a lot of the times they haven't. And someone made a statement about someone by themselves. That's one of those patient admissions I used to get on my palliative ward all the time, and it was crisis situation, and the 80-year-old neighbour next door was looking after this poor person by themselves at home, and nothing had been put in place. And that's why it's so important to, I was sort of cheered when you said that, so important to think about those people, because they're the ones at risk. And these conversations need to be taking place, and start thinking about who is going to make those decisions for them. So again, it's about 10 questions. I just want to point out question 9. Now 9 basically states, is there anything else you would like the practice to know about your future healthcare wishes? Now when I used this tool, it was really interesting, and I want to share 2 examples. One person had this terrible angst, and often working in palliative for so many years, sometimes I've often noticed that people have this worry and they can't get past that worry. They can't think of anything else because there's this particular worry that's embedded in their brain. And this particular worry was this lady, she was 75, 78, she had high blood pressure, she had witnessed her mother-in-law years ago die having a stroke, and no one tried to communicate with her. And she was absolutely terrified that she would have a stroke because she had high blood pressure, it was being well maintained, but that was her fear, that no one would try to communicate with her. And so we wrote, because there's a really nice section here where you can write in more detail, if this lady does have a stroke, 2 blinks means yes of the eyes, 1 blink means no. And you could see the relief sort of coming off her, and then she could start thinking about other things. But she could never quite get past that. Now another really interesting feedback I got from one male patient when we went through this tool was actually nothing to do with healthcare wishes. It was to do with his internet banking and his banking details. He was the patriarch of the family, and he was really, really scared that his son, his eldest son, because he wanted to pass it on to his son, did not know all of his internet passwords, his banking details, his shares. Nice to have shares, wouldn't it, I have to say? Shares and all his portfolio. And so we wrote that down. And then he could get past that, because he really wasn't even thinking about his healthcare wishes. That was what was so important to him. So this really pulls out all these different types of angst and worries and concerns. Now the Advanced Care Plan screening interview again, we have a web link you can attach onto there as well. Click onto that, and that will direct you to the Advanced Care Planning website. So you can access what's your state or what's your territory, because we don't go into that in this session, because every state and territory is different. Different legislations. In New South Wales, we don't even have one advanced care plan that we actually use. I know that Tasmania does. You use Melbourne's ones at the moment to see the latest ones that they're recommending. That's quite handy. And plus there's a link here to the RACGP Advanced Care Planning, which basically states that advanced care planning should be discussed within the general practice setting. So let's have a look at Paul talking to Caroline. While we're looking at the interview, just look at how he's using the tool, because the important point of this is you don't have to memorise the questions. You can actually use the tool in front of you, and it makes it a much more streamlined conversation. You don't go off in tangents. If you're a bit like me, I'll start wandering off and start talking about something completely different. This keeps you on track, and it keeps the person you're interviewing on track as well.
So Karen, if it's okay, I'd like to work through a few more questions with you.
Yes, okay, love. What are these ones about?
Well, as part of the seniors' annual checkup, we ask everyone about their future health wishes. Are you okay to talk with me about this for 5 to 10 minutes?
Yes, of course. Well, what is it you want to know?
Well, the first question is, have you ever thought about who you would like to make medical decisions for you in the event of an emergency, if you were too unwell to speak for yourself?
Oh, well, let me see. Since Frank died 5 years ago, I've more or less been attending to things myself. And Andrea, you know, my daughter, she's intellectually disabled. Well, you know that. So I wouldn't want to burden her, Paul.
Of course, that makes sense. Is there anyone else, a close family or friend, whom you would trust to make decisions about your healthcare on your behalf?
Oh, let me see. I've got my niece, Sally. She's an absolute darling. I babysit for her sometimes. And she and her husband, well, they often help me around the house with things, you know. And she's a nurse, so she gets this stuff. I've got a brother, he lives interstate now, but he and I aren't that close. Do you know, I think Sally'd be the one. Yes, I think Sally. I'll talk to Sally.
Okay. The next question is, have you ever signed a legal document to appoint someone to make health decisions on your behalf if you were unable to?
Well, I've got a will, and I've made sure that all my finances, you know, are there to look after Andrea. Is that what you mean, Paul?
Well, no, there's a separate form that allows you to appoint someone to make healthcare decisions on your behalf.
Oh, well, maybe I should get on to that too. I can talk to Sally about it, if she doesn't mind. Now, where'd you get these forms from?
Well, there's a website that we can look up that gives some information about things to consider when appointing someone to make healthcare decisions for you. It can also tell us where to get the forms that you need to fill out and how to get them witnessed so that they, if you wanted to say have Sally on the form, how to make it legal. I can print up some information for you if you like.
Oh yes, thanks.
All right. Now the next question says, have you talked to anyone in your family or a close friend about your wishes, values, beliefs about medical treatment and care in case you became seriously ill or unable to make decisions?
Well, I haven't spoken to my daughter. I mean, it seems weird now that everything's okay. She wouldn't understand all that, and it might end up by distressing her.
Yes, I can see how that could be hard for her. But, you know, sometimes making these decisions when you're still okay enables you to make, well, good decisions and to think clearly.
Yeah, well, that makes sense. I mean, Frank and I had this talk before he died. He went very peacefully, Paul. And that's what I want for me.
Well, have you ever talked to a doctor about your wishes, cares, beliefs about medical treatment and care in case you became seriously ill or unable to make decisions? Or have you ever written them down?
No, but maybe I should.
Well, that leads on to the next question. Have you ever heard of an advanced care planning or an advanced care directive?
No. What's that?
Advanced care planning is a process that helps you to plan for your future medical care. It involves thinking about your values, your beliefs, your wishes about the medical care that you'd like to have if you became critically ill or injured. It's a way to make sure people involved in your care understand your wishes in regards to medical treatment and care. And you can write these down in a document called an advanced care directive that records your specific wishes in the event of serious illness or you know, even if there is any treatment that you would specifically want or would not want.
Right. So that means that I wouldn't end up like Mary. Oh, sorry, Paul. Mary, she's a very dear friend, and she now lives in a nursing home with a feeding tube, and she had a stroke. She no longer is able to speak, and when her friends and family visit, well, she doesn't recognise them. Does that mean that this advanced planning, care, I wouldn't end up like Mary?
Well, it allows you to make your own choices about the care that you want to receive in the event that you are sick and aren't able to communicate clearly or make the decisions like Mary can't.
But that sounds really good. No one's ever mentioned this to me before.
Well, it's like you said, it's not so easy to bring these up sometimes. So, would you like some more information about advanced care planning?
Yes, that would be good, Paul. I could take it home and maybe talk to Sally about it, and eventually, perhaps, include my daughter Andrea.
Maybe we can talk about this next time you come in. We could arrange another appointment.
Yes.
Maybe even bring Sally in.
Oh, yes.
And to discuss it with her as well.
That would be good. It would be good to have Sally here and to talk about these things. Yes, when shall we do that?
Well, do you have a preference for who you would like to discuss this with here at the practice?
Oh, well, you, I'd hope, Paul, and Dr. Joel as well. But I think you first of all.
Of course. Is there anything else that you would like the practice to know about your wishes, your priorities when it comes to your healthcare?
Well, I don't want to suffer, Paul. Don't let me suffer. Or distress Andrea. I don't want to end up in a nursing home with a feeding tube and not recognise her. And I want Andrea to be taken care of. So, when can we make this appointment?
Well, that's up to you. We can organise it for next week if you like. Thank you for sharing your thoughts. It gives me something to think about that we can discuss next time when we meet.
Yes.
Do you feel comfortable with our conversation today?
With you, Paul? Very comfortably, yes. You know, it's a hard topic to bring up, I know that. But I'm so glad that we had this chat.
Good.
In that conversation.
He made her feel very relaxed.
Yeah, it did, didn't he?
In some way, she led the discussion.
Absolutely. But the use of him using the actual tool, did that take away from the conversation?
No, it just progressed it.
It progressed it. It really did. Because when they actually evaluated this, it did not take any longer from around about 10 to 15 minutes. The average was around about 5 to 8 minutes. So the outliers were, so it's not something that's this conversation is going to go on. And it really gives everyone an opportunity to be on the same level playing field, to really find out what have they heard, what do they understand about advanced care planning. It's not because you're going to be dying in 2 weeks. As we all know, palliative is basically just non-curative treatment. So let's look at Mrs. Smith. Now she's 60 years old. Just turn over the next few pages and there should be a blue spic guide on the right. Now she's got lung cancer with bone and liver mets. She's had some radiotherapy, her chemo, she had 1 round but it was stopped because of side effects. She's on MS-Contin for pain. She's lost 20 kilos. She's chaotic, BMI is 18. She has a husband of a stroke and she's the main carer. And her husband's actually in a wheelchair. Now Lucy, who's a supportive daughter, they've both come in to have a flu vax. And Lucy's very worried about her mum for obvious reasons. So what's the first thing that we should be triggering? What should we think? Looking at the advanced guide, what type of patient does she fit into? Because she's literally not over 75, so she's not coming in for a 75-year-old and health assessment. So that's not really triggering you. Absolutely. So the second type of patients that this type of assessments really, really help is the aged 18 years and over with 1 or more chronic debilitating illnesses, including frailty. And Mrs. Smith definitely fits into that. So the second thing that we're doing, what's the second thing we're looking at? Looking at your advanced guide. So let's ask ourselves that. Would you be surprised, looking at her case history, would you be surprised if she died within the next 6 to 12 months? No, absolutely not. So that's a question you've asked yourself. So to confirm your suspicions, we're going to be looking at the SPICT. So this is our second screening tool. Now the SPICT stands for Supportive and Palliative Care Indicators Tool. This has been around for a while. So when our advisory board did the LIT review, we pulled this one out because it was actually very well known. It's actually used in Adelaide, South Australia's end-of-life pathways. It's a very well known. I do want to add there's a new version that's just come out in April. And I can send you the link and the copy if you want to. It's very much the same, it's just the wording's changed a bit. So we'll have a look at that, but the essence of the actual indicators are the same. But I just wanted to make sure that if you do see this around, there is a new version out. So what is the SPICT? It's an assessment tool to confirm your suspicions that Mrs. Smith, for instance, looking at Mrs. Smith's case scenario, is going to be needing more care very soon. And you do this with your GP, so it's a conversation. So you're using this. When I use this particular tool, I was with Dr. Jolan, you'll see him at the end, and in one of the little videos, and we sat in front of his computer with his list of patients because I didn't know the patients, I didn't work with him, but he used the surprise question and the SPICT and identified 5 or 6 patients for me to go and interview using some of these other tools. So there's 2 main indicators. You've got your general indicators of deteriorating health, and then you've got to look for your clinical indicators of 1 or more advanced conditions. So the rule of thumb is, when you're looking at the SPICT, if they basically tick a couple of boxes in your general indicators and your clinical indicators, maybe 1 or 2, then they what's called is meeting the SPICT criteria. So basically confirming your initial thought that yes, this patient is at risk of deteriorating and dying fairly quickly. So let's have a look at the general indicators. Unplanned hospital admissions. Performance status is poor or deteriorating. For instance, significant weight loss is a key one in palliative. Mrs. Smith definitely has that, doesn't she? And then you've got persistent symptoms despite optimal care. And then, of course, the person or the family are asking for palliative care. The clinical indicators, you've got the primary, you've got cancer, dementia, frailty, neurological disease, vascular, respiratory, liver and kidney. So just thinking about Mrs. Smith just for a moment, which one in the clinical indicators would she tick? Because if you look under that, functionability deteriorating, too frail for cancer treatment. So really, she's ticked one of those boxes already, and thinking about her again, in the general indicators, which one does she tick here? Absolutely. And that she is deteriorating, but a significant weight loss. So again, this is one of the second assessment tool, and it's a conversation you're having. One of my GPNs that I'm mentoring at the moment, what she did, and I thought we should have done it if we had more time, is she laminated the SPICT and stuck it under each GP's door or in their pigeonhole. And she would have these conversations in the corridor. Never minimise the power of the conversation in the corridor using a SPICT, because it really is a conversation. So it's nothing that you have to completely, there's not a lot of work, and you're doing this anyway, but this is really just using a specific tool to really confirm your suspicions. So, using this, we've decided that yes, Mrs. Smith is absolutely at risk. Now, this is Dr. Jeff Mitchell. He's from Queensland, and he is part of our advisory board, and he helped actually develop another couple of the assessment tools we're going to be discussing, talking to Kate. Kate is an actor, but she's also a nurse. And they're using the SPICT tool. We'll have a chat about it after. Again, this is on the website, guys, if you haven't done the online training.
Morning, Kate. A little bit tired. You've got a kickstart there.
Yeah, I didn't get much sleep last night with Jack having the flu.
Oh, yeah. 5-year-olds don't do very well with illness, do they?
No, definitely not my boy.
Yeah. Hey, I was looking at Marcus the other day. I'm quite concerned. He's not doing very well.
Yeah, I was wondering how he was going. The last time I saw him, he was very, very tired, and he wasn't even complaining about his wheelchair like he normally does, and he still won't take all his meds all the time, and I mean, he's adamant about not having dialysis for his renal failure, and Danny looked frazzled and yes.
Yeah, oh, Marcus is a tough one, all right. He's got such an illness burden. He's had heart attacks and diabetes, COPD, arthritis. He's done really well up till now. However, I was having a look at this SPICT, this tool that looks at needs, and I just wonder whether he's should benefit from a supportive care assessment.
Yeah, gosh. He does tick a lot of boxes. He's in his chair more than 50% of the day. His carer needs both for him and for Danny. His low BMI, plus his other health problems, and he's in the kidney disease category, so as well as all his other conditions.
Yeah. I don't know what you thought last, but when I saw him last week, I asked myself that question, would I be surprised if he died in the next 6 or 12 months? And I'd have to say, no, I wouldn't be surprised.
Yeah, I'd have to agree.
Yeah, all right, well, if you could arrange that assessment, that would be good. And we need to do everything we can to help him. Oh, and when you see Danny, I wonder if we could get her to do that care and needs assessment as well.
Yeah, I want to make sure she's doing okay. She's coming in for a flu shot, I think, soon, so I might just have a bit of a chat with her then.
Good.
Yeah.
Okay.
And sorry, Jeff, I was just also thinking about Connor. I don't know, like, you know, he's coming in to have his stitches removed. You know, he cut his shin on that piece of glass a couple of weeks ago. I was just thinking, you know, metastatic prostate cancer, increasing PSA, heart failure. I wonder if he'd be a good person to do a full supportive care assessment on.
Yeah, I hadn't really thought about it. He's seeing his oncologist soon about future chemotherapy.
Yeah, in a month or two, but he's not sure he's going to accept chemo. Yeah, I just, you know, looking at the SPICT, his function's not great. He's lost weight, and the last few times I saw him, I was worried he was getting depressed. So, yeah, he's got no one around, you know, with his son overseas, and, you know, he's going to need more care soon.
Sure. All right, well, it sounds like he does need one of those, a supportive care assessment as well. Yeah. The SPICT tool is interesting, isn't it? It helps you to clarify that gut feeling that you get.
Yeah, that's right, yeah. Actually, do you mind if I hold on to it? I might have a look through some of the other patients that we've got coming in today and just see if there's anyone else we should have a think about.
Sure.
Yeah. Okay.
See ya.
All right, see you later.
So what was interesting about that particular scenario is that Jeff's come up to Kate to talk about a particular patient using the SPICT. And because Kate's looked at the SPICT, it's highlighted to her another patient, Connor, and when you've done the online training, all these videos of all these patients are actually there, and they go through each one of the tools as well. I highlighted that he's going to be, he ticked some of the boxes as well, so he is at risk of really, and when I was working in the palliative ward, particularly on a Friday, we used to get those admissions that is when everything fell apart at home. People have been going on, and suddenly, boom. And if something like this had been in place beforehand, it definitely would have been a huge advantage. So, we've decided that yes, we've asked ourselves the question of Mrs. Smith. She is at risk, we think, of dying within the next 6 to 12 months. We've confirmed that suspicion using the SPICT tool with the GP. So now we're looking at deciding she does need a full supportive care assessment. Now, what does that include? That's what we're going to look at now. The advanced care plan screening interview, which we won't go into detail now because we did that with Mr. Barrows, but definitely we need to start talking about that with her. But let's look at the IPOS. Now, the IPOS stands for Integrated Patient Outcome Scale. I went through a few of the workshops when I went completely blank at this point, and then Jane would automatically say, Integrated Patient Outcome Scale, but I've remembered it today. So this also, from the Lit Review, has been pulled out from England. Now, what's so good about this tool is if you notice, there's not one word mentioning the word palliative in there. So that's why it was seen to be, you can really use this beautifully within a general practice setting when we haven't actually discussed palliative with that patient. Of course, we will be at some stage, but at this stage. And what this tool is that you hand it to the patient to complete. I love this tool. I used this about 5 or 6 times, and I sat with them because I was sort of practicing it. But if you're really flat out in your practice, and we understand, we really do, how busy you are, you don't really have to sit there with them. Not one person that I spoke to had an issue filling it out. They actually seemed to gain quite a lot out of it, and they didn't have any trouble completing it. So let's have a bit of a look at this tool. It's a list of questions, really. Like, the first one is, what have been your main problems or concerns over the past week? So the whole point of this is to get their point of view, what's really affecting their quality of life. Now, when I handed this out and I sat with them, any ideas of what might have been some of the concerns or problems that they highlighted in that section? Anyone would like to guess? Or make a stab at?
The decline in their activities of daily living, like difficulty shopping or
Absolutely.
energy,
Yep.
lack of sleep.
That was certainly one. Absolutely, that was certainly one of them. Any others? Pain. Absolutely. Who said pain? Absolutely. And I'll go into that shortly because that was actually a bit of a surprise. But there was another couple which I found quite interesting because this is something that's affecting their quality of life. One gentleman said, I've got this terrible taste in my mouth and I've got this terrible dry mouth and I'm not enjoying any food. And I keep forgetting to talk to my nurse and my GP about it. So it's a really a way of streamlining the actual appointment when they do come to see you or do come to see the GP. Another gentleman said, I've got this wound on my leg. I was told to cover it up with a plastic bag and tape it before I go in the shower. And I keep forgetting to ask the nurse in the treatment room, do I still have to do that? Because it's a pain in the bottom having to bend down all the time and actually put this plastic bag on. I mean, it is, I know it's for me. Never mind if you're elderly and you've got arthritic issues. So it's a way of streamlining their meeting with the GP or yourself and getting their concerns, what's really affecting their quality of life. Now, if we go down to the next question, below is a list of symptoms. Just indicate over the past week, how have they been affecting you or not affecting you? Now, this is where the pain came into it, because every single one of these patients had actually written moderate to severe pain. They've been suffering. Not all the time. It was normally on movement, on having a shower, but they hadn't really spoken to the doctor about it. And this was Dr. Ree's patient. When I actually completed these and scanned and sent it back to Joel, he was actually quite shocked because none of them had mentioned. They were on painkillers. They were on Norspan patches and Panadol, etc. But obviously they need something a bit short-acting. But for them to look at this tool, it almost gave them permission to actually be honest about how they're feeling. Because if it's in black and white, that must mean other people are suffering as well, and I don't want to be a burden. They're very stoic patients, aren't they? They really don't like to, not all of them, but most of them are. Yeah, no, not all of them. And then you've got shortness of breath, weakness or lack of energy, constipation. Oh, Jen's waving at me. Drowsiness, poor mobility. And then there's a list of 3 questions here. Please list any other symptoms not mentioned above and tick 1 box. This is something you might just want to point out. If you look on the back page of the tool, there was one question which I have to say made me laugh a bit because each person who I asked it to sort of went, what? It's question number 6. Have you felt at peace? And I remember this one old lady saying to me, I haven't felt at peace in years. What a dumb question. I just thought it was quite amusing. And I said, well, that's fine. But there was that sort of comment back. So it was sort of a bit of a joke. That's what I'm saying. It was really interesting. And another one was, which tore at my heart, was one of the 3 questions, what's worrying you, is that out of 5 patients, 6, 3 of them said they were scared of being lonely. And this was in the community sector. I actually used this tool for someone in the aged care sector as well. But we can do something about that. We can get volunteers in or community or something like that. So this tool, again, can be given to the patient in the waiting room to complete. So something like the advanced care plan screening interview, you would need to have a sort of a private area. This one you can just use in the waiting room. I did, and there's nothing really major that's going to be a problem there. But it's a great tool. And then we've got this next couple. Dr. Jeff Mitchell, that was in the video, talking about the SPICT. He helped develop these two couple of tools, the NATCC for the patient and the NATCC for the carer. We just turn over the page. And what this tool is, so just after the IPOS tool, this is instructions for use. This stands for Needs Assessment Tool for Chronic Conditions. So I think of the IPOS as sort of like symptoms, and these tools as more concerns. So these are a list of concerns that someone with a chronic debilitating condition may or may not be going through with this. Now, where I found this incredibly useful was when I used it with carers, plus patients, but it really tore at my heartstrings. One particular carer who was a daughter looking after her mother. And I was actually using this tool with her in the waiting room because her mum was seeing a specialist doctor. And she said, well, why, I'm not the one that's sick, why are you trying to assess me? And I said, well, you're the main carer, and if you fall apart, everything falls apart. And that's when we used to get the urgent admissions into palliative, is when the carer fell apart. That's when it all happened. She was in her 40s, working full time with children. And so if you look at it, it's got domains of areas. And what we're looking at here is information issues, practical issues, relationship issues, and also there's a list of top 3 concerns or questions which they might like to speak to their doctor now or later. It sort of looks quite a lot, but it really isn't. Because if you look through the different information issues, for instance, if they don't really have an issue and they don't really want to talk to their doctor about it, they don't tick it. You go on to the next one. When I was using this with this particular daughter, it all came out. Her mother wouldn't tell her anything. She had no idea. She had huge information issues, no idea what was going on, her trajectory, when she was going to have to be maybe admitted into a specialist palliative ward. They were fighting all the time. Her mother hated her giving her a wash, a personal care. It all just came pouring out. And so basically we sat there and I thought, well, let's get some community, some support in here, blah, blah, blah. I mean, I'm not going to be able to solve it all, but at least we've identified it, and then we can start linking her into some sort of community care or et cetera, et cetera. But it was really, really valuable. Again, this can be done at home. I went into community and sat with people at home and do it, and they can bring it in. So it's something that they can actually do themselves, and no one had an issue completing it, because it's really quite straightforward. Again, it's streamlining, it's making tangible their fears and concerns. So again, the IPOS is something the patient's completing. The NATCC for the patient and carer. The carer and the patient one are very similar. The domains of concerns are the same. It's just tweaked whether you're a patient or whether you're an actual carer. They're completing. So if you look at the assessment tool so far, the first one is the surprise question, which is a question. The second one is the SPICT, which is a conversation. The third, you've got your IPOS, you're giving to the patient. The fourth and fifth is the NATCC, and of course the Advanced Care Plan screening interview. So out of all of the assessment tools, the one that probably takes the most amount of time to do, up to about 5 minutes, is the Advanced Care Plan screening interview, which you can utilise, and we'll talk about that in this challenges and strategies session when we're going to actually utilise this. Because you're having these conversations anyway. Could be over doing a dressing or something, or flu shots, etc., etc. This is a very quick video. There's a longer version. Now this is Kate talking to Marcus. Marcus was one of the ones they identified using the SPIC tool with Jeff in the first video. And this is Kate introducing the concept of what we're doing here, of full supportive, what that means to him. There's a longer version on the webpage.
So, what new thing have you got in mind for me to do today?
Well, Marcus, I know that you've been dealing with your kidney problems for quite some time, as well as your other conditions, and I think you've been a bit more tired lately. Would you agree?
Well, yes, but I'm battling on.
You are, and you're doing very, very well considering. So Thank you for coming in today. The reason that we're here is we want to take a step back and ask you some questions about your thoughts, your concerns, how you're going, and your priorities, so that we can really make sure that we're providing you with the best care for you.
So, you want to know what I want?
That's right.
Really?
Yes, Marcus, we want to make sure that we understand your side of the story as the person who is going through all the things that you're going through. So we want to make sure that we're on the same page and we're doing everything we can to make your life as good as possible. How does that sound?
Good. Sounds like a good deal. So what do we do now?
And our next phase is how do we evaluate the patient's and carer's needs. So let's have a look at the referral triage tool. Now what this was developed by our project team, our advisory board. This is on page 30, I was going to say 32, 30. But after seeing you for the full supportive care assessment, the completed tools are provided to the GP who can review them before he sees or she sees the patient or carer, and the patient's responses to the advanced care plan screening interview to see if that conversation needs to be continued, because obviously it's more than one conversation, and looking at the symptoms, concerns and questions. So again, it's really making sure that the time they have with the GP or yourself is really being utilised, because you've done a bit of this pre-work before, or the patient or the carer has. So with the referral triage tool, this is what this tool, again, is a guide, and this is our last assessment tool, to see whether your general practice, your environment can look after that patient's and carer's needs, or do we need to start linking in to different specialist providers. So let's have a bit of a look at this one. There's only one page. So basically the first question is, after assessment by the practice nurse and GP, consider, can this patient and their family carer supportive care needs be met at present by the GP practice and the current support systems in place? Now, if we think of Mr. Barrows, our first patient, what would the answer do you think would be here? Yes. So, yes, let's go down to question 4. When does the patient or carer need to follow up by the general practice? General practice nurse follow-up, this could be to do the advanced care plan screening interview, GP. But if we think of Mrs. Barrows, what do you think the answer might be there? What's your gut feeling? No. Exactly. And so then we've got questions 2 and 3 that you can talk to your GP about. So the first question is, if the answer is no, consider what additional support may be needed. And these are some ideas. This is a guide. So what sort of things do you think Mrs. Smith may need, for instance? Community nurse. Do you think she might need a community nurse at this stage to go in and maybe help with her husband? We could start that we could start sort of doing something like that. A counsellor, a psychologist, a social worker, physio, an occupational therapist. I love OTs, and I never really worked with them until I was working in a palliative care specialist. They go out to someone's home and they just do a few changes, and people can stay there for much longer. So it's sort of triggering what else will be needed and who do I need to start linking into? Because sometimes it can be a little bit confusing. And getting to know what is in your area as well. Do they need an ACAT done, for instance? Now question 3 is referral to a specialist palliative care service required? And again, these are like prompts. So if you think of Mrs. Smith, for instance, which one do you think she would tick? Unresolved physical symptoms, maybe? She's sort of deteriorating. Unresolved psychological symptoms, care family distress, anticipated difficulties of end-of-life planning. That goes perfectly to the person who's by themselves and there's no one there to actually look after them. So they're triggers, they're guides to make you think that maybe we need to start linking in to either sort of community support, OTs, or maybe let's look at specialist palliative care. Because when you're looking at pain and symptom management, the specialist palliative unit, the specialist palliative doctors, that's what they do really well. Because everyone is so completely different, as you know. Again, if referral to specialist palliative care is required, you click onto this link. It's a directory of services. And again, I really advise you to click on it and have a look to see what's in your area. Again, we can't actually state that because it's too different wherever we go. But it's getting those relationships with, you know, specialist palliative care unit or the pain clinic. Do you have one in your area? So for instance, at Barwon Health, where Jen and I went for one of our workshops, they've got this fantastic model, and I spoke about this at that table, where the local health district actually funds 3 nurses to go out and do advanced care planning. So for instance, if you're in a general practice, you've identified someone, you've started doing the advanced care plan screening interview, you would ring them and they would go out and actually complete the advanced care plan. And they state that that particular structured interview took about 20 minutes off their time because a lot of the information was there that they could start. But that model is not everywhere. We wish it was, but it's not everywhere. But it's understanding what's in your area. And that's a great link. And then there's also communication tips for discussing referral, because if the patient needs specialist palliative care, you've got to have that conversation. And that can be a little difficult. But there's some great tips on the Advance website of how to actually approach the subject, and there's some videos as well. Because again, all palliative, as we know, is non-curative. The end of life is one of the phases of palliative care. I mean, we discharge people from my unit. They would go home, we'd sort their symptoms and pain out, they'd go home, they may come back in 6 months, but it's not all about we've given up on you. This is about making sure your quality of life is improved. So that's the Advanced Referral Triage tool. It's a really good guide. So let's just recap quickly before we go into case number 3. So we're looking at a suite of assessment tools. We've got the surprise question, which is a question you're asking yourself. We have the SPICT, which is used as a second screening tool. If you think that the answer to the surprise question is no, you wouldn't be surprised. You use that with your GP. You've got the IPOS, you've got the 2 NATs, which the patients are using, and the carers. And that's to gain information, to streamline your actual meetings with them, to find out what their issues are. And then we've got the Advanced Referral Triage tool. Can you look after their concerns and their needs, or do you need to start linking into different providers, and how do we actually go about doing that? Some practices have wonderful links. I know in some of the country areas they seem to have really strong links with different providers. It seems to change a lot. We've got CDC now, and there's always different changes. So, case number 3 is we would like to start using some of these tools. We would like to introduce the Advanced suite of tools into your practice. You're going to go to work tomorrow and go, woohoo, how do we do this? How do we introduce this to the GP? Let's think about how we're going to get started. Now, this is Dr. Jolan, who is on our advisory board. He's an absolute delight. His acting skills are a little wooden, but he's absolutely gorgeous. I sat with him in front of the computer with the SPICT and the surprise question, and he's marvellous, but just look at his acting ability is a little wooden, one could say.
So
he's
Joel,
actually really funny.
Last week, if you remember, I finished the training package to screen patients in the practice who might benefit from an introduction to advanced care planning or a full supportive and palliative care needs assessment.
Oh, great. How did it go?
Yeah, good. Really interesting, actually. And I'd like to give it a go. You know, start by screening our patients who are coming in for their 75 and over health check. That way we can make sure that, well, we're not missing anything with our older patients, you know, in providing care and support for things that, well, they might not think to ask about.
Sounds good.
Yeah. You know, we probably should consider any of our patients over 18 who might benefit from a supportive care assessment.
Sure, happy to talk about it too.
Yeah, I'm seeing Caroline Whitting today for her 75 and over health check.
She's been well, hasn't she?
Yeah, she has. So there are 2 tools that we can use though, surprise question and the SPICT. So the first thing to consider is the surprise question. Would you be surprised if Caroline was to die in the next 6 to 12 months?
Yes, actually, quite surprised, to be honest.
Yeah, me too. So, since both of us feel that it's unlikely that Caroline would die in the next 6 to 12 months, in fact, she's doing rather well, there's no need for a full supportive care needs assessment at this stage. Though, it would be good to include an advanced care planning screening interview in her 75 and over health check. In the training, they said that that's a good way to encourage early consideration of advanced care planning, especially in our elderly and chronically ill patients.
Yeah, I'd be interested to see the results of that actually. If it works well, it could be a good way of introducing advanced care planning into all our over 75 plus health assessments.
Yeah, I agree. Also, it'd be good to chat through some of our chronically ill and frail patients, you know, to see if any of them would benefit from a supportive care needs assessment. I sometimes feel that we're missing something with these patients if we don't ask the right questions.
Yeah, by the time they come in and we address their presenting issue, we kind of run out of time. And it'd be good to get onto these issues earlier rather than later, before it becomes too late. And it's good that you're initiating the discussions rather than me. So I'll be on the lookout for any patients that you might want to speak to.
Yeah, thanks. Don't suppose we could spend a few minutes of the morning meeting just reviewing the book patients each day? You know, we could start by asking the surprise question as an initial screen, you know, and then if both of us feel the answer is no, then we move on to the SPICT as a second screen.
Sure. Shouldn't take too long, should it?
No, it'll be pretty quick. And the more we do it, the quicker it's going to be as well. I might also keep an eye out when I'm reviewing patients' notes. It might trigger something. So we should also talk about the flu vax.
Yeah, it's meant to be deadly.
It's not on the video, on the web page. So anyway, so that's our lovely Dr. Joel. He's actually hysterical. We were doing a bit of a photo shoot and we just couldn't stop laughing. But so we're going to look at now challenges of introducing this in your environment, in your general practice. So who would like to pop their hands up and say, what's the first challenge, do you think? Time. So let's unpack that a little bit. What is it about the time? What is really concerning you about the time?
Well, our health assessment's booked in for half an hour with a nurse.
Half an hour.
And they go to
Right.
So if we're late,
Yeah, it's snowballing effect. So you're looking at, in particular, the advanced care plan screening interview in that sort of issue, because when you think of time, again, this is a whole suite of assessment tools. So the surprise question is the question. So it's more the advanced care plan screening interview seems to be the one that people need to, you've got to think a bit about how we're going to introduce it. So is there any other way? Let's unpack that. What are some strategies we could do?
Is it possible to add another 15 minutes hold on for that appointment for the nurse? Or I have 45 minutes.
Yes, 45. Yeah, that's...
Especially some people, when you ask them about their medication, 15 minutes later they're telling you when they went off and all, and I'm like, yeah, like is that something you can talk to your practice manager about?
Is the billing, I think the billing is different depending on how long you spend. It's time for 1 days. Are you aware of that, Liz? Like whether in terms of the billing arrangements?
Yeah, it is.
So it might be possible to actually, because that's one way you can actually build the time you might spend with advanced care planning screening interview, whereas if you just did it at another time, you wouldn't actually necessarily be able to, you might not be able to build for that time. So, one thought is to, if it could work for the schedule, you may still be able to through duration of that.
And if you do it as part of the GP management plan, you can use 10917 to bring them back, and you could actually break it up and you have to do it all in one.
Could you speak a bit louder? Sorry, everyone, I'm sorry, but this is great information.
I just said if you're doing a GP management plan and you included the initial screen, that then you could bring them back on using the 10997, and you don't do all those things at once, but you could bring them back 2 or 3 times to split it up.
Do exactly, because we tend to set ourselves up here, but we really need to think about these assessment tools, particularly in the advanced care plan screening interview, is that it's not going to happen maybe in one session, but it's utilising it, pulling it out the next time you speak to someone in a different, you could be doing a dressing, for instance.
I actually think one of the challenges is actually patient information overload.
Yes.
Sometimes, because you tell them, look after your diabetes and check your feet,
Yep.
do your eyes, and by the way. And so I think, sometimes it's good to split it up.
And it's good to be able to give them something written.
Absolutely.
So they can talk to family or think about it. Or we do too much verbal.
Yeah,
Not
nurses love verbal. It's our biggest downfall.
Nurses are less guilty of it than GPs.
Oh,
Invariably they come
in
out
wards.
of the GP and they say, what am I meant to do? And I think,
I don't know, I wasn't there.
It says to my GP, please write down, 1, 2, 3, do this, if this happens, do this, Too much verbal.
Too much verbal.
What's the cost to the patient if they're coming back? I don't really understand the billing system. So if you're getting a patient to come back and back.
Speaking up just a little bit.
Sorry.
Sorry, I was just wondering what the cost to the patient is if you're getting them back.
Depends on your practice.
Depends on your practice.
Can I just make a comment about that? You're talking about cost. I think of it in terms of time.
Yes.
You're asking patients who are maybe old, frail, have difficulty getting to and from, to come back another time because you're basing it on cost. I just want to throw it out there, having supported a number of people.
No, absolutely.
At the end of your life, the thing you really don't want to do is spend the last bit of your quality bit of your life sitting in some GP surgery or hospital.
No, that's a good point.
That's a really good point.
It's a great point.
Do you have any thoughts about how you might then just in practice incorporate something like this into
Don't actually, because I don't work in a GP practice and I never have. I'm really sort of speaking from a personal point of view, having supported people through it, watching them sit through appointments, and you think, was that really necessary?
No, was
it really necessary
all
for me to
conscious of
sit here
that
for an
too,
hour waiting to answer those questions? I just wanted to throw it out there so you think about it.
Sorry, I was just going to say, I really think it depends on the quality of your rapport you can develop with patients, how you approach patients. Because I know most times when I do chronic disease and health assessments, patients will thank me and they'll say, I want to see you again, I'll only book in with you. So sometimes I think that can be an individual thing with nurses. If you've got, because I always say to new nurses, you have a small window of opportunity with a new patient to make that impression and make them want to come back. And I always have a goal to personally say, I want to make that patient want to come back to see me. I'm not saying everyone does it that way, but if you make it worthwhile, if, so for some patients, after the long wait in the waiting room, if they've had a great time with you and with the GP and they've got something out of it, they will come back. Not all the time, but most of mine do.
And my experience is that nurses run on time.
Yeah.
Yes. Oh, yes.
We have to. Yeah, look it up to you.
I wasn't thinking even as much of you running on time. It's that whole concept of, towards the end of my life, all of a sudden, my life is focused on, I have an appointment with the OT, I have an appointment with the physio, I have an appointment with the nurse, I have an appointment, oh God, and now I've got to go and see the palliative care specialist, and, I just don't want to do it anymore.
No, I agree. You're going to be very difficult to manage patients.
Yes.
It wasn't difficult to manage patients. But it was just that for him, and possibly if you'd had these screening tools about at that time, one of the things that he would have said in what's important to him was, I want to live my life to the full.
Exactly.
And that's the thing, I spent, I think I had about 4 visits from the Blue Nurses to organise some sort of help with care, and he actually died before they ever actually gave any care. It was all 50 million sheets of paperwork and questions, and
But I think
Bonnie
just said it beautifully. She said we should be implementing this before we get to
Exactly. Because it's actually reducing the time they need to come in, because you're actually identifying and assessing their symptoms and concerns in a much more streamlined fashion. I'm sorry, you wanted to say something?
Can I just comment? My name's Gavin. I spend a lot of time doing advanced care planning conversations. And one of the things that I often do is actually start a conversation over the phone. So I will actually give a certain amount of information over the phone. I will say, can I send you something in the mail? When you come in for an outpatient appointment, because I work in a hospital environment, can I catch up with you then? And usually I'll ring them beforehand and say, have you thought about who you might want as your substitute decision maker? Is it possible to bring that person with you? And by the time I've actually got to that point, I've actually covered a lot of ground without actually spending a lot of time.
Or bringing them in for extra time.
If you're talking about people bringing people back in for extra time, then you want that extra time to be valuable. You want to actually be able to have a reasonable conversation. You want the right people there. So I'm then wondering, well, how much of this can you actually do by phone? Especially, as you say, it is very difficult to get those people back in.
I think the idea of the advanced care planning screening interview is to streamline some of those things so it comes into a routine health assessment.
Yes, which
and
I
so
think
that
is
the
a great
seed is
idea.
planted early.
Yes.
And so it's really about, we're not, often the screening interview only takes about 5 minutes, and it's just a streamlined way for you guys, because you might not have time to be ringing up patients as in your role as general practice nurses. But if you can incorporate those questions into your routine health assessments, it just finds out whether that person this is something they're ready to maybe think about and have some follow-up consultations with, or not. It may be something you just raise at the next year's 75 health assessment again. And also just that planting that seed. So I think the two things in your routine health assessments would be the advanced care planning screening interview and the surprise question.
Yeah.
If there are people where you wouldn't be surprised if they died, then that's when you might need to start to think about some more proactive care planning, having a conversation with the GP, and then working out how you might be able to incorporate some of these other assessments.
Well,
that's a little segue into our friends from Decision Assist are here, Kathy and Michelle, and they're doing a session this afternoon that you may all be going to. Sorry.
Yeah. Can I just add one comment as well? I think the other thing to realise is that there's not going to be one solution that's going to actually work for every single practice. Every practice obviously works very differently, and I guess it's about thinking how you can enact this in your practice, because often you see this new nurse intervention or new way of doing something in practice and you go, oh, that's really great, but that's not going to work in my practice. But it's about thinking about how can you tailor this to what's going to work for you, and thinking about how can I actually go back to my practice on Monday and make this work.
So what else? What other challenges do you think? How would you introduce this into your practice? We've discussed about time, cost. What are some of the other issues?
In general practice, we are just bombarded with forms and
of course.
Services, and it can be very, like, I come to work on the practice matters as well, so I come to work and there's just so much stuff. Like my Medicare liaison officer comes down to all these initiatives on my desk, and you just can't implement everything. And it can
No, of course not.
And so sometimes the GPs can become a bit resistant because they are very pressured for time and they have a lot of work. So sometimes implementing new things, I think you really have to demonstrate the value of it first.
Perfect.
So maybe do it and then, because
how would you demonstrate that?
I'll probably just do one, and my principal is pretty proactive. I do a lot of 75 plus with him. I'll probably just do it and then turn up.
And how would you choose which GP to chat to first? The nice ones. It was interesting.
Well, yes,
The more receptive ones.
He's very, we kind of work well together and forward thinking. I'm pretty lucky that I can just initiate things. I don't have to ask him these days.
Not
everyone's got that.
Yeah.
In that position, especially if you're in a corporate.
No. One of my GPs that GPNs I'm mentoring said, actually, Jolan, I approached one of my other doctors who I thought would be really resistive to this whole concept, and he wasn't. He was actually quite open, and he's actually been one of the ones that's been a real advocate. So sometimes I do think, and it made me think about this, that we put those blinkers on ourselves a little bit sometimes, but because children, yes,
realise that they don't have to do a lot of work.
Exactly.
That's what they are.
Another lass, what she did was presented at a clinical meeting one case scenario where it all went to pot on a Friday evening, and the GP had spent a lot of time and it was a nightmare, and if this had been in place, she basically said if we'd had this in place, this never would have happened.
and the light bulb sort of went off in that situation as well. So it's just thinking about ways of introducing. Maybe it is just doing it. Who would be sort of agreeable about, or would be able to use some of these tools?
I think the screening and that would be, I mean, they take a lot of time, so they'd be pretty easy to start maybe with that, and then gather momentum.
It really is. I mean, choose your patients carefully too. We had this question when I was at Liverpool, and they said, you know, this person doesn't speak English, blah 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 blah. And I said, that's one day we'll have all these tools, hopefully in different languages, whatever. But at the moment, start off with the patients that you do know well, is going to be receptive. You'll have some more confidence, and the more that you do it, the more streamlined you become about it.
I think it's like when I first started 75 health.
Yes.
And sometimes I get to 75 who are just so fit and healthy, and they sit there and, you know, why am I doing this? I go, you know, we do this because, you know, now that you're, you know, 75, things can change from one year to another so quickly.
Exactly.
And so it helps us kind of make sure that, you know, we, you know, providing you with the support you need as things change. So while it might seem trivial to do it today, next year it could be a different story. So I was kind of presenting like that, but I think it's a great way of, you know, offering, like, sort of bringing the topic of advanced health.
I just think of the IPOS, it's perfect. Like a gentleman that had the wound and he'd been putting this plastic bag on his leg every day for 2 weeks. He only needed to do it for a week. So it's more, that's not rocket science. It's actually quite a simple thing to change and to say, no, you don't actually have to do that. And his life has just been improved. So it's for the patients to make sure that they don't forget to ask the question. And something like the NATCC for the patient and carer, they can take that home if there is not the time.
You could send it to them and put a prepaid envelope.
It's whatever works.
Take it home, send it back to me in some envelope.
I know in Melbourne they had a red envelope, didn't they, at one stage, Jen? That they had a lot of, and there was more advanced care planning.
Personal interaction is what, in terms of the research suggests that patients really value having a nurse introduce this, for example. So just sending it in the mail, like in some qualitative interviews we've done, we've had some, unless it's actually introduced in a personal way, maybe that the...
No, but like after you've had that face-to-face conversation.
Right. Yes.
You could say that and you've taken them, you know, like you've already introduced that.
Or even like if it's in that society, you could say this might be something you might want to think about and bring with you when you come for your next appointment. So it's, because I think like there's quite a lot of personal stuff on the NATCC, so just putting in the mail kind of might feel a bit like it's depersonalised, but it's about them having a bit of the patient having a bit of a sense of control that they can guide the conversation with the GP as well about the things that concern them.
We've all done that. We've walked out and went, oh, I forgot to ask them this, and this.
And some GPs aren't very comfortable having the conversation either.
Exactly.
Having the tool and identifying some needs, then they can actually go ahead and have that conversation.
Sure. I think you get, if you do a good job and patients give positive feedback back to the GP.
Yeah, it's a ripple effect.
That nurse was, you know, she was fantastic. I've never spoken about this before. They then will say, oh, that will spur them to then encourage that to happen in practice. So sometimes you just got to take that leap and do it.
So who else in your practice would you need to discuss this with, and how would you do that? Practice managers. So how would do you have clinical meetings? Because I know one of my GPNs is actually presenting it, I think, on Tuesday at her clinical meeting. So what other avenues? Some people don't have clinical meetings. We've really found this, is everyone's GP practices run so differently. Email? Like one of my GPNs, she laminated the SPICT and the advanced guide and plonked it everywhere in front of people in a tea room, have a chat. It's really just remembering, and one of them said, just you ringing me actually reminds me to do it. It's remembering. So let's get down. Who else? So you've got your practice manager, reception, and Jen will talk about some tools that we've got to be able to promote this as well to people, practice managers, GPs, etc.
And as I was mentioning to you before, Jolan, I found some of my GPs were very concerned and very stuck on there being legal implications to them doing advanced care plans, and that was often the thing that was the barrier.
Okay.
So when I've raised it previously, not knowing much about it, not having any tools,
Yep.
they said, oh, no, there's too many legal implications to this.
And I'm under the impression that in Victoria there's going to be some change to the
Yes,
legislation.
there is.
It's going to be compulsion to complete, so we do need to get our head around that bit.
If you direct them to the RACGP website, it actually states in there that advanced care planning, the best area is to be starting this in the general practice and initiated. So it's something that you can actually... Definitely. So what other challenges are there?
There are leaflets, like just general leaflets that we have now in the waiting rooms and things that people do pick up occasionally, which I think is a good idea. And we have a retirement village very close to where I am, and so they have had lectures and things from various people, or talks, when they have their little social get-togethers, their Friday happy hour. They have had people go and talk regarding that, which has been good, just as an introduction of what it is, because people say, well, not generally now, but they have had times when I've said, I have no idea what this is about, it's too hard.
It's one of those things, it's really understanding what advanced care planning is, and the fact is you can change it. It's only when you don't have a voice. And I think it's that people forget that part. It's like, no, you just given up on me, I'm doing an advanced care plan. Absolutely not. It's when you don't have a voice, and it's really looking at this earlier on than later, what you would like, and that could change, as Jen said before. So what are some of the other things that would make it difficult? There's a section on page 32 that would make it difficult for you to implement these tools into your practice. Now, what are some of the other things that we might be looking at? On page 32, there's an area that I'd like you to write 3 things that you could commit to, but realistically commit to, which could just be finish the online training. Introduce the online training, the website to your other GPNs. Let's get some support. So, because we've got 19, 20 people here, there's over, I think it's 4,000 GPNs, general practice nurses, around nationally. And again, it's you guys being the advocates and getting them to do it so they're aware of it, so they can support you as well. It could be printing out the SPICT, for instance, getting it laminated. So something realistic that you can actually achieve. Maybe using the IPOS tool on a couple of patients, or booking in the advanced care plan screening interview, talking to a GP about it. But make it realistic, because this is not going to happen in a week or 2 weeks, but we have to start somewhere. And I think that's, who was the lady, was it in Victoria, who did that audit? And that really struck me.
That was another state.
That was another state?
Because they're easily identified.
They were doing that from a hospital perspective. They were doing an audit, and it was heartbreaking. They had a number of 90-plus-year-old patients who died on trolleys and corridors in the emergency department, for the fact that they haven't had their issues documented or known. So residential aged care facilities have put them in an ambulance and so they do that even though
She was so passionate. She said even if the discussion had been had with someone, that wouldn't have happened.
And it still does.
Yeah, I'm sure it does. Absolutely.
In some places it will.
Would anybody like to share anything they've written down that they could commit to? You don't have to. Anyone would? Exactly. And you're already using some of the advanced tools. And that will lead on maybe when you've identified them and go from there, because it's not going to happen in one hit with one conversation of this person. These tools are for a period of time. And anyone else like to share something they could commit to?
The screening tool, I would have made it as a template on our medical software, because the staff have enough scanning to do as it is.
Yep.
It's just enough scanning, and that way you can, you can put in as you go with the patient. You can write stuff in, and then it's easily accessible to everybody, rather than having to.
And we're actually developing. It's just being tweaked at the moment. A fillable PDF of the advanced care plan screening interview. So that should be ready. Yeah.
Fillable PDF, because then you're going to save it somewhere. Then
I know.
Remember
It's a start, though.
We can have like best practice and medical, kind of templates, like you said. It's just,
Yep.
The doctor's more likely to use it
Any referral that's like in the templates and best practice and that, they're more happy with it than going to find.
No, I get that. Yeah.
Certainly we would, love to move towards that way.
But, I mean, you can easily create them yourself, like
But yeah, that's where we'd like this project to be expanded, and you could do help.
This is just the beginning.
Yeah. This is a time where everything that.
I just wonder if general practice accreditation has anything about advanced care planning, because if it was something like you must have 10% of your patients have advanced care.
It's a good one.
That would drive GPs to do it, because you don't credit your practice, you don't get any money.
That's a great thought.
Well, I guess, if you think about online health records, that's a good reason to do it, because there's something to upload. And
Exactly.
upload,
They have to upload something. That's a perfect thought.
But you can look at it, accreditation terms, it's quality improvement.
Yes.
So that would meet that criteria, but I get what you're saying, having a KPI.
Nothing like a stick, is there?
Anyone else would like to share something they could commit to?
I'm a senior nurse in my practice, and I've got 3 other nurses working with me, so I'm just going to look at our next week's health assessment bookings, educate the nurses and say where we're going to do one this week, come back to me and we'll see if we go.
Brilliant.
I just thought, and that's a start, and it's just simply using that advanced screening thing, so we can just slip that in and just get some feedback from that.
Excellent.
But the other thing I was thinking too is it's the follow-up, like in that thing where you're saying, do you want to see a GP or RM or whatever? I think we probably need to book that appointment.
Yes.
And what we do at the moment in my practice is when we do care plans, I'll say to them, well, we want to see you in 3 months' time, can you book that appointment now? And all our patients do, they're really good, they'll book their next 3-month appointment. Some people, we could do that at the same time. So, we give them enough time to do it though, because it's, it's getting other family members in. I'm thinking maybe trying to do that as well. So could we book that care plan appointment? And we get our receptionists to ring or SMS the night before to remind them they've got a care plan and health assessing appointment, so we do that too.
Oh, excellent.
I work in a large group practice. We've got 4 practices. We've got 22 nurses.
Wow.
In the practice that I work in, that's across the 4 practices. In the practice I work in, we've got a full-time chronic disease management nurse, care plan nurse, and a full-time diabetes nurse. She does diabetes. Helen does everything else. So when I go back, Helen's not at the conference, which is really unfortunate. So when I go back, I'm going to have a chat to Helen about this, because that's all she does all day.
Oh, perfect.
We've got a contractor that does our over 75 health assessments, so they come to the practice to see the GP, but they don't actually see a nurse. There's a nurse that goes to the home, and that's all she does. So she's the other one that I need to have that conversation with and sort of get some resources together. And I've got to talk to them and find out actually how much of this they do, because I don't know that they do this per se. So that's what I've taken out of this.
In the survey, because I'm going to pass on to Jen at the moment, there is a space saying if you'd like some mentoring, pop your name down. Because at the moment I've got about 10 people who are looking at this actual 3-hour workshop, and we're condensing it. So if you're working with a lot of nurses, you could be part of the trainer, and you could actually show this sort of thing, but much more condensed. And it's a way of sort of delivering it at a clinical meeting or et cetera, et cetera. So if you're interested in that, just make a note, and so that I can actually contact you, because it's sort of being reviewed and developed at the moment. I'm going to hand over to Jen.
Okay. So in the interests of getting us out to lunch, let's talk about what next, and a lot of this you've already just touched upon. So it can be as simple, and particularly when you were just talking about the other nurses in your practice, get them to do the online training. All the content's in there, they'll get access to the tools. That's the best way to spread the word to the others, so that you're not the lone voice. And also when you're saying talk to the people who are going to do the over 75s, that's a way of them feeling more confident about it if they do the online training as well and get a bit more information. Of course, you've already identified the best way to do is just start with the patient, and then you feel confident about it, you're showing the benefits of it, and you can then feel better about going to speak to your practice about putting it in place. We've already spoken a number of times about the mentoring, and it's on the survey if you would answer that question. And lastly, Oh, and also when you're introducing it to in your packs, you have some information sheets. So if you want to go back and talk to people, there's one in particular called about the advanced project. So when you go back to talk to your practice manager or the other nurses, it's a question and answer type thing that tells them who we are, what the training is, so that you can easily give them something or photocopy it to present to other people. There's also a information sheet about the mentoring program with Jolan. And lastly, as part of the bigger research project that we're doing, we would really like you to use these tools on your patients, but not only that, to give us the information back so that will help us know how your patients filled out the answers, and we can then put that into the research element and the evaluation of this project. So there's a couple of loose leaf forms for you in your pack. One's called Information Sheet for your GP and General Practice Managers about the clinical audit. It's very important that we get their consent. If you're going to do it, it'd be de-identified data about your patients. It's been through Sydney University Ethics, and that will help answer their questions about all of this. There's also an information sheet for you to know what we'd like you to do. So it's the clinical audit information sheet for general practice nurses. That tells you about would you be able to use it on some patients and feedback to us the de-identified data about it. We would like to reimburse you for your time, because we know it will be your time. So we have a gift card of $100 that we will give to you if you're able to give us some of your de-identified patient data, and we'll also give a small token of appreciation to the general practice because we're using their patients of $170. But that's all documented there on those information sheets, and by all means email us to get in contact and we can help explain it more or help explain to your practice if you think that's something worthwhile. So if you're going to go out there and use it, we'd love to have your feedback about the tools being used on your patients.